Okay, hopefully you guys can hear me. I'm going to get started a little bit early today because we've got a lot of stuff to go over. We're talking about benign melanocytic proliferations, which obviously means nevi. So when you talk about pigmented lesions, people generally are referring to melanocytic lesions in that situation. And so there are many, many of these. I've got 19 things to look at, so I'm not going to spend a lot of time with each one. So um, basically go back and review the video again. There's a lot of good information in here. I'm going to mainly go over the criteria for diagnosis and then tell you a little bit about the clinical that you'll need to realize it. So the first one of these, punch biopsy, is a Becker's Nevis. Now, Becker's Nevis, as you all know, these are brown pigmented lesions usually on the shoulder. They are basically almost kind of like simple lentiginous. Mainly you have hyperpigmentation at the basal cell layer and these elongated epidermal rhescia that kind of look like little box cars, if you will. They're usually all pretty much the same size. They extend about the same depth into the papillary dermis here. And they don't really have a lot of melanocytes. It's mostly just kind of hyperpigmentation of the epidermis that we're seeing here. So it kind of looks like a simple lentigo with acanthosis. And then the other thing that's commonly seen in a Becker's Nevis is an underlying smooth muscle hamartoma. So you'll see an increase in the number of smooth muscle bundles in the dermis in most of these lesions. You don't have to see that, but it's seen most commonly with Becker's Nevis. So that's Becker's Nevis. If you just saw this blind without any information, you might think it's a macular seborrheic keratosis. If you got a superficial shave biopsy of this, it could look like the surface of a dermatofibroma. So just realize that the findings are not wholly specific and they have to be taken in context of the clinical information and the underlying smooth muscle hamartoma to make a definitive diagnosis. Okay, this biopsy is taken by shave technique from the lip and from a mucous membrane site. And the main change here is hyperpigmentation at the basal cell layer. This is an example of a mucosal lentigo. These are the same types of lesions that you see in the labia or on the genital, usually the glans penis of men, and also on the lip. So they all basically look the same. And this does have a proliferation of melanocytes, so it's not purely just epidermal hyperpigmentation. Here you actually do have an increase in the number of melanocytes and melanin at the basal cell layer. And if you look carefully, you can't see it here, but if you had a special stain, say a Fontana-Masson stain or S1 protein stain, you see that there were dendrites, maybe seeing right here, that extend from the basal cell layer, usually no higher than about the lower part of this acanthotic epithelium. So generally, if you see dendrites, they kind of go right around in here. If you see thick, fat dendrites that go all the way through to the top of the epithelium, you need to be concerned that you may be dealing with an early melanoma, acral lentiginous melanoma of mucous membrane sites, because it can look just like that when they're really, really early. So you don't have to see pagetoid spread of melanocytes. You don't have to see striking atypicality of melanocytes. You're looking for enlarged, elongated dendrites that go throughout the epithelium. That's a sign of early acral lentiginous melanoma in situ occurring on the mucous membranes. So just remember that. And this also looks similar to what you see in acral lentiginous melanoma in the nail unit or even on volar skin. So they all can kind of look similar. So beware of that. But if you just see this pattern here, very common lesion, many of these get sent into us as rule out melanoma. They're not melanoma. This can involve a broad area, but generally they're usually relatively small and they usually are quite symmetrical and they're usually kind of dark. You may get some melanophages that you see down here, like in this situation over here. So this is labial mucosal lentigo, totally benign. A couple other things to put in the difference diagnosis. Sometimes you can get macular pigmented seborrheic or condyloma acuminata. So those can sometimes look sort of like this, but they're not usually as darkly pigmented as this. And the pigmentation there is seen throughout the epithelium, not just at the basal cell layer. And there are no dendritic melanocytes in that lesion. It's basically, you're just looking at pigmentation. So it's epidermal pigmentation, but that's something to keep in the different diagnosis of a labial or mucosal lentigo. The next one of the lesions we're going to look at basically is an example where you see a nevus that This is actually not what it's labeled to be. This is basically just a blue nevus in this case. So there are a couple of different kinds, there's several different kinds of blue nevi. There are nevi that basically are so-called common and cellular blue nevi, which is really not a very good terminology, by the way. A common blue nevi, basically what you'll see in the dermis is just a puddle of pigmented dendritic melanocytes, usually in a small little clump. Sometimes you'll see larger lesions that have some sclerosis associated with them. So, for example, here you've got some of that. You've got these spindle cells here. So this would actually, probably a better term for this would be a spindle sclerotic blue nevus in this case. This is an example of that. And if you're just to look right at this area alone, I mean, this was somebody had written in here, this was an example of his nevus of Oda, which is not an example of nevus of Oda. But if you saw only this area here, it could theoretically be what you see in a nevus of Ito or Oda or a Mongolian spot. Those lesions, when you look at them under the microscope, just show basically an interstitial pattern, relatively sparse and low powered, almost looks like it's normal skin. Go to higher magnification, you'll see these dendritic melanocytes that are present diffusely in the reticular dermis. So if you just saw something like this, it could be an area of a nevus of Oda or a nevus of Ito or a Mongolian spot. But if you see something like over here, it's way too cellular. So we don't see this in nevus of Oda or Ito. Nevus of Ito, nevus of Oda, those are basically macular lesions. Clinically, they just look like a grayish area. They often will, especially nevus of Oda, get into the sclera, the conjunctiva of the eye. So basically, that's what you see when you see a nevus of Oda. This would be more of a spindle sclerotic blue nevus over here. Okay, another area, this is the previous biopsy. So this basically shows the same kind of change. Some people, you may have heard the term malignant blue nevus. Basically, that's not a very good term, but what it really refers to is a melanocytic blue nevus that has undergone malignant degeneration into melanoma. That does not happen, thank goodness, very frequently, but it can happen. And when it does, it obviously is not a very good sign because it's usually the lesion occurs kind of deep when that happens, and it can be associated with a bad prognosis. Another example of a blue nevus here. So again, this has got a prominent, very heavy pigmented pigmentation in these cells here. You've got some thickened sclerotic collagen in the background. It's basically relatively small. It's pretty symmetrical. So again, this is a probably, we'd call this maybe getting close to a cellular blue nevus when you've got this many cells associated with it. There's still a bit of sclerotic change too, so it's got some sclerosis in it. And blue nevi quite commonly will give you some sclerotic collagen, but this would be a nice example of a more of a cellular blue nevus. And all of this is melanin. Sometimes there's some concern that this might be hemosiderin or some other kind of pigmentation, maybe iron or something like that, or silver or some other metallic foreign substance. If you're not sure, you can always do a special stain for melanin. Fontana-Masson stain highlights that, and it's a black color. It's a silver stain. So you could do that if you want to confirm that this is melanin, but this is a pretty straightforward situation here. Variant of blue nevus, more of a cellular blue nevus. So again, sometimes the different diagnosis of this might include a cellular dermatofibroma. The pigmentation in the dermatofibroma obviously is iron or hemosiderin, so you might want to do a stain if there's a question of the diagnosis. You can also stain the actual cells, looking for positive staining with S100 protein or with basically factor 13A if it's a dermatofibroma. Okay, so shifting gears now. This is probably one of the most common lesions that we get biopsy. This is just a garden variety intradermal melanocytic nevus. Shave biopsy, a dome-shaped papular lesion, and you can see it's comprised of these nests of cells here that are small and typical. And sometimes in an intradermal nevus, you'll see a little bit of junctional component as well. If you get compound nevi and you get an intradermal nevus underneath it, you can sometimes see a little proliferation, sometimes even of single melanocytes overlying the intradermal component. That doesn't mean the lesion is developing into melanoma. That's a very common finding that we see overlying the epidermis of an intradermal nevus. So again, there's no atypicality, and sometimes these lesions, if they've been around for a long time, they become neurotized, and they begin to look like a neurofibroma. So that can happen when you get a late stage intradermal nevus. And these are thought to arise initially as compound nevi. Gradually, the cells go into the dermis, and then they eventually end up like this, an intradermal melanocytic nevus. Now, sometimes the nevus cells can not develop features of a neurofibroma. They can develop more of a kind of look almost like a tendon, if you will. And this is an example of a so-called desmoplastic nevus. And obviously, when we think of desmoplastic nevus, we obviously have to be concerned about the possibility of desmoplastic malignant melanoma. So how do you tell those apart? Well, desmoplastic melanomas have the architectural features of malignancy. They're broad, they're asymmetrical, they're poorly circumscribed. They have atypical cells. When you do the higher magnification, you'll see mitotic figures, and you'll see very marked pleomorphism of the nuclei. We don't really see that in this case. We've got the desmoplasia, which is basically, that word comes from the Greek word that means tendon. So it means it's almost like a tendon that you're looking at under the microscope. The cells have acquired these characteristics that almost look like the collagen bundles. So here's some normal dermal collagen. This is the desmoplastic nevus component. And you can see that it really almost looks like collagen in many ways. These lesions are often usually very, they feel sclerotic clinically, as you would imagine, because they've got this sclerotic desmoplastic morphology to them under the microscope. And you also usually, in a desmoplastic melanoma, will see these little nodular aggregations of lymphocytes and plasma cells, which we don't see here. So this was a benign lesion. It's a variant of a nevus, and just realize that it's one that we see on occasion, and it can be sometimes difficult to distinguish from other desmoplastic lesions, including melanoma. If you just had a shave biopsy of something like this, you probably would get a recommendation to go back and re-excise the lesion. But this was a totally benign lesion in this case, and it's got all the features of benignity. It's relatively small, quite symmetrical, and was totally excised with the biopsy, and vertically oriented wedge shape to it. All those features are benign. And then cytologically, there was no striking atypicality. So that's an example of a desmoplastic nevus. Sometimes they can be compound. You can have a junctional component. This one maybe had a little bit of that, but in many cases, they're basically just an intradermal basic variant of a nevus here. Okay, this one is a nevus. It's a compound nevus. It's a shave biopsy. And we're going to higher magnification. It's comprised of nest of melanocytes at the dermal junction and also in the papillary dermis. The nests are relatively large. They are not really coalescent, and there's really no pagetoid spread. There's no striking cytologic atypia. So this is an example of a compound nevus, but it's taken from a special site. This was probably from near the groin area. And there's certain parts of the body, when you biopsy nevi in those locations, they look a little bit different. The scalp, some of those nests usually tend to be a little bit larger, and you may get some slight coalescence and some hyperpigmentation of some of the melanocytes there. Nevi taken from the genitalia and the groin often look like this. The nests are relatively large and again can have relatively abundant pigment in their cytoplasm. Nevi from the breast they kind of look like dysplastic nevi, and not uncommon there to get a little bit of slight pagetoid spread, but you do not see mitotic figures, and you have the other architectural features of benignity, small, symmetrical, well circumscribed. Those various features are all seen in nevi from the breast. Lesions in flexural areas kind of look like nevi from the groin. Nevi from the ear commonly look like they have a spitzoid morphology quite commonly. And nevi from acral sites often have a little bit of pagetoid spread. You may have some dendritic melanocytes. So those are all different special sites, if you will, where we see slightly unusual features. So this is a lesion that's got some of the larger nests that would be seen from, say, one of those special sites. I think this may have come from the groin in this situation. And so it's important to recognize some of the lesions from some of these areas can have some slightly unusual features. And so you don't want to overcall these lesions as malignant melanoma, especially if it's in an area, say in the genital area of a younger person. If you call that melanoma, well, they're going to get a wide excision and deforming surgery. So you certainly don't want to overcall something like this. So if there was ever any concern, You could consider doing things like genetic testing, things of that nature, to make sure that you're not dealing with just an unusual simulator of melanoma in that situation. So that's a so-called special site nevus. Sometimes we get nevi that can have more than one morphology in the specimen. This is an example of a lesion that has got melanocytes in the dermis, and notice how they're kind of splaying between and among collagen bundles and also around some of the adnexal structures. This is a nice example of a congenital nevus. And basically, congenital nevi not uncommonly give you this pattern. They tend to, it does have a little bit of a junctional component still here. They may or may not have that, but it's got the nice sort of almost plaque-like morphology. It's distributed over a relatively broad front. And notice how the cells in the dermis are present kind of between and among collagen bundles. Congenital nevi can have different patterns to them. Sometimes they can have heavily pigmented areas. You can get heavily pigmented clones, separate individual proliferative clones in congenital nevi. Sometimes they can look a little bit atypical, but generally you don't get mitotic figures or striking atypicality or any of those kind of things. If you start seeing that, you need to make sure you're not dealing with malignant melanoma. So again, this was an example of a variant of a congenital nevus that's got this heavy pigmentation to it. Sometimes we see lesions that look like garden variety compound nevi that are more heavily pigmented. Sometimes they get called combined nevi, where there's features of a blue nevus and then a garden variety banal nevus as well. I don't think I would consider this one a typical combined nevus here. I think this is more of a congenital nevus. It just has some heavy pigmentation in it in a couple of areas as well. But this is a nice example of the variant of a congenital nevus here. This would probably not be a giant congenital nevi. If you biopsy this giant congenital nevi on trunk, those kind of areas, those lesions generally will extend far throughout the dermis, go all the way down to the base of the specimen, sometimes even into the subcutaneous fat. So that's what you see in a in a congenital nevus, like a giant congenital nevus, say in a baby that gets biopsied. And some of those lesions can also be associated with leptomeningeal involvement in some cases too. Okay, this is a biopsy taken by shave technique. It also this one came from a child. And notice that it is again, we're going to assume this is pretty much the entire lesion. It was not thought to be cancerous or malignant in any way. And notice that it's comprised of these nest of melanocytes that are epithelioid in morphology. And they're arranged, the epidermis is hyperplastic, there's hyperkeratosis, hypergranulosis, and the nests have these clefts surrounding them. They're almost vertically oriented. There's some pigmentation in some of the areas over here. There may be a little bit of pagetoid spread, which is not uncommonly seen in some of these lesions. And this is an example of a Spitz's nevus. This was actually seen in a child. And, this demonstrates why it may be difficult to diagnose these lesions in some cases. They can give some pagetoid spread. They usually don't have striking cytologic atypia. But when you see, pagetoid spread, as you see here, that can sometimes be a feature that can cause some concern about the diagnosis. People say, oh, pagetoid spread, well, that's obviously seen more commonly in melanoma. Therefore, we got to get concerned this might be a malignant melanoma. Just realize that you can get pagetoid spread. You can see mitotic figures sometimes in Spitz's nevi, and it still does not mean that it's malignant. Obviously, if there's concern, if it's an adult, for example, we often will recommend re-excision. But in a young individual, like a child, we would not necessarily always recommend re-excision in a case like this. So this was an example of a Spitz's nevus that had more of a kind of a heavy pigmentation, and the so-called pigmented spindle cell neoplasm, pigmented spindle cell nevus of Reed, those lesions commonly will be associated with some relatively areas that the lesions are heavily pigmented. So again, this is an example of a Spitz's nevus. You're looking for, the other name for that is pigment of spindle and or epithelioid cells. You're looking for relative small size, symmetry, epithelioid cells, and in some cases spindle cells. Here's another example of the lesion taken in another area, which shows basically the same thing. So if we see something like this in an adult, if we start seeing mitotic figures, any asymmetry, anything like that, my rule of thumb is in an adult, it has to be pretty much perfect for it to be a Spitz's nevus, or it's more likely to be a malignant melanoma. In a child, It has to be pretty much perfect to be malignant melanoma. It can't just have one or two criteria. It has to have pretty much every criterion for melanoma, or it's more likely to be a Spitz's Nevis. So just kind of keep that in mind also when you're looking at these spitzoid melanocytic lesions. Sometimes in Spitz's Nevi, we can get desmoplasia in those lesions also. And this is an example of a lesion that has also got this prominent desmoplasia associated with it. And if you start looking at higher magnification, it's got these nests of cells or epithelioid, and some of them are multinucleated. And so once again, you've got a melanocytic lesion that's associated with this very prominent desmoplastic stroma. And this is an example of a desmoplastic version of a Spitz's Nevis. And there actually are some genetic abnormalities that have been associated with this. These lesions are quite commonly associated with 11p gain or loss, or in some cases, I believe it's an HRAS, NRAS mutation can be associated with these lesions. So if you see a desmoplastic Spitz's Nevis, they're very commonly associated with 11p genetic mutations. So if you just had a biopsy of something like this, like by punch technique, where you really couldn't assess breadth, symmetry, circumscription, some of those features, we obviously would be concerned about the diagnosis and might even do some special stains to make sure that we weren't dealing with some other kind of desmoplastic lesion. And we might even, obviously, would want to get good clinical correlation in a case like this, and might want to make sure that we weren't dealing with the desmoplastic malignancy. But the lesions, the cells themselves are quite small. They're very typical in appearance. There's really no mitotic figures. So putting this together with the clinical in this case, I believe this came from a young individual. We felt pretty comfortable about the diagnosis, and it was an example of a desmoplastic Spitz's Nevis. So again, just remember that you can get desmoplasia in Spitz's Nevi, as well as desmoplasia in malignant melanoma, and in other kinds of nevi as well. Okay, this is a lesion taken by saucerization technique. This also came from a young individual. And notice that it's very small. It's symmetrical. You can draw the line of where it extends right here. It's mostly junctional in its morphology. And it's comprised of these very heavily pigmented cells. And we're going to higher magnification. You can see they have abundant cytoplasm. There's a little bit of slight superficial involvement above the dermatdermal junction. And a lot of these have relatively abundant cytoplasm. So this is an example of a mostly junctional, heavily pigmented Spitz's Nevis of Reed, a so-called pigmented spindle cell tumor of Reed. And some of these have more spindle morphology than others. This is a nice example of a camino body right here, dull pink globule in the epidermis. And the Spitz's Nevi very commonly have these camino bodies within them. Some of them have a large number of them. Some of them have just a few, as you see here. But notice that it's got some slight pagetoid spread here, and it's got the very heavy pigmented melanocytes, but it's obviously a benign lesion. It's very small, it's symmetrical. This came from, I think, from like a 10-year-old kid, something like that, from a pediatric dermatologist. He really strongly favored the diagnosis of pigmented spindle cell tumor of Reed, and that's actually what this is in this case. So nested mostly, you can get a little bit of pagetoid spread. You can get abundant melanin in the cytoplasm of these cells. So this is a nice example of so-called pigmented spindle cell tumor of Reed, which is a variant of Spitz's Nevi. So there's a whole family of Spitz's Nevi. You can get desmoplastic Spitz's Nevi. You can get the mostly epithelioid cells in the Spitz's Nevi, the mostly spindle cell type of Spitz's Nevi. You can get combined Spitz's Nevi. You can get BAP1 mutated cells within Spitz's Nevi. So there are a lot of different forms of Spitz's Nevi, and this is just one type of those. So just want to make sure you kind of understand the overall subtypes of Spitz's Nevi. Just realize that this is not a malignancy, and it's not something that you'd have to get too overly concerned about. And just realize it's a variant on a theme. Now, the next one of the lesions we're going to talk about is a so-called Clark's Nevis or dysplastic nevi. And these lesions are seen very, very commonly. They're probably the most commonly melanocytic lesion that we're getting biopsied today. The reasons for that are twofold. Number one, patients that have a lot of these and have a family history of melanoma, they have an increased incidence of melanoma. If you just have a few scattered lesions with no family history, the risk of melanoma in that situation is really not significantly greater than that of the general population. But if you see someone's got a lot of these lesions, you do need to make sure that they don't have a family history of melanoma, or they don't have a personal history of melanoma, and they are at a higher risk of getting melanoma if they have a lot of them. So these are people you need to follow. And one of the reasons we get a lot of biopsies is because clinically they can look a lot like melanoma. They can be dark brown, they can be asymmetrical, they can have areas that if you take a dermoscopy, they can be dark, they can look like a malignant melanoma. So you do have to beware of these lesions because they can simulate melanoma clinically, and histologically it's usually not too difficult to tell them apart, but clinically they can look very much like melanoma sometimes. So how do we diagnose them? Basically, they tend to be relatively small. They can be, relatively large in some cases. They can get up to like, centimeter in size. They can be, some of these dysplastic nevi can be pretty large lesions. They're usually, though, quite symmetrical. They don't usually have a significant pagetoid spread. They can have a little bit of involvement above the dermatodermal junction. Usually, if you see cells that go all the way through the cornified into the granular cornified layer, and there's asymmetry, well, then we get concerned that it might be evolving into malignant melanoma in those situations, but it's not uncommon to see an occasional cell focally above the dermatodermal junction like we're seeing here. You'll see fibroplasia surrounding the nest of melanocytes at the dermatodermal junction. You'll also see what's called lamellar fibrosis, where you get like strands of collagen just beneath the nest of melanocytes. This is a junctional dysplastic nevus in this case. And you'll also see bridging of the nests of melanocytes like you see over here. So those are all the classic features that we see with the dysplastic nevus. We'll see some sprinkling of lymphocytes in the dermis as well. Those are all the histologic features that we see. So if you start seeing asymmetry, you start seeing any mitoses in the lesion, you start seeing cells above the junction, start seeing more cellularity with coalescence of nest of melanocytes and coalescence of single melanocytes predominant over nest of melanocytes, that's when we get concerned that the lesion may be evolving into melanoma. Now, there's a lot that's been written and said about grading dysplastic nevi, and basically, I'm personally not a big fan of grading these lesions, but a lot of clinicians want them graded. They're taught in the residency that they can be graded as mild, moderate, and severe. And I can just tell you, having looked at slides now for over 30 years, and having probably diagnosed several 100,000 of these maybe in my career, it's really very, very difficult to draw the line between something that's mild and moderately dysplastic. Criteria in the literature are poor. There's really no something that everybody would agree that, that's obviously moderately dysplastic versus mildly dysplastic. We've tried, we've said we've had panels of dermatopathologists, and no one can really agree on it. The most important thing is whether it's benign or malignant, whether we think there may be melanoma in situ arising in the lesion. And if we see features like I mentioned before, asymmetry, pagetoid spread, any mitoses in the epidermal component even, that's a sign that it's possibly evolving into melanoma. And some people may call that a severely dysplastic nevus. That's fine if you want to call it that. Those lesions all need to be excised. If somebody calls something moderately dysplastic, it probably means they're not sure about the diagnosis. It probably means that they think it's benign, but they're not sure. They're saying, well, let's call it moderate, and clinicians often will re-excise those lesions if you call it moderately dysplastic. So really, there's only two grades, mild and melanoma, or possibly evolving melanoma. It's not on the same spectrum as like an actinic keratosis evolving towards squamous cell carcinoma. If you leave an AK alone long enough, many of them then develop into squamous cell in situ, and then many of those develop into fully developed squamous cell. Or sometimes you go from an AK just directly into the dermis as a squamous cell carcinoma. So this isn't the same thing. If you look at the genetics of the cells involving this lesion, it doesn't look malignant. If you look at the genetics of an actinic keratosis, it looks malignant. So this lesion, melanomas may arise in association with them. Melanomas may arise in association with compound nevi, with intradermal nevi, with congenital nevi, with these nevi. So basically, yes, melanoma can arise within them. And if it isn't, if you do happen to catch it when it's arising in the lesion, that's probably when a lot of people call it, quote, severely dysplastic, or we call it melanocytes arising in these lesions in many cases. So just so you'll know, there's a different school of thought about whether to grade these or not. This would be, if I were going to grade this, I would call it mild. I wouldn't worry about this. I wouldn't recommend re-excision. I wouldn't raise any red flags about it whatsoever. So that's kind of dysplastic nevus in a nutshell, the Cliff Notes version of it. So here we've got a shave biopsy. This is a lesion that, unfortunately, I think it's not as good of an example as the congenital nevus we saw before, but this is an intradermal nevus that's got some involvement around adnexal structure. So it's probably a superficial shave biopsy of what could be a congenital nevus. So again, it shows the same kind of changes we showed you before. When the nested melanocytes start clustering around the adnexal structures in a more diffuse pattern. Sometimes people say that this is maybe in this case, an intradermal nevus with features that could be a congenital nevus. Again, benign, nothing to worry about. We don't recommend re-excision. Years ago, there used to be a big debate whether congenital nevi were precursors of melanoma. And the giant congenital nevi, yes, those have a very high incidence of developing melanoma in them over the course of a lifetime. Unfortunately, it's impossible to completely remove those lesions. So given that they have a sea of melanocytes, some of them may develop into melanoma over the course of a lifetime. And it'd be nice to be able to remove all of those. Maybe some of the BRAF drugs today or MEK inhibitors, things like that, could be used to treat those gargantuan giant congenital nevi. But you can't cut those out because they're too big. The small congenital nevi, you can cut them out, like here, but they don't have a higher risk of melanoma. So there's no need to cut them out. So unfortunately, the small lesions that you can remove, that you don't need to remove, don't have the higher risk of melanoma. It's the ones we'd love to be able to get out that we can't, that are deforming and unfortunately are really problems that we run into with those situations there. Sometimes we get a lesion that's got a very dense infiltrate of lymphocytes in it. And, we look at it and say, gosh, that could be a halo nevus. But clinically, it doesn't have any halo, which is interesting. And then sometimes we'll get biopsies from clinicians that say halo nevus, and it's just an intradermal nevus, or maybe it's an area of just depigmentation with no nevus cells left at all, with no inflammation left at all. So there's kind of a clinical pathologic discordance between halo nevus and the microscope. So sometimes we see, the histologic features that look like a halo nevus, like here. We've got a very dense inflammatory infiltrate. We've got some residual nest of melanocytes up here. And, we say, gosh, that looks like a halo nevus, but the clinician said, well, there's no whiteness there. So just so you'll know, you can get nevi and get lots of inflammation in them, but no halo, and halo lesions clinically with no inflammation. So here we've got one that fit. This one was a halo nevus, had lots of inflammation, lots of lymphocytes in it, and had the obvious residual nest of melanocytes. And sometimes you'll get the halo area where there's just tons and tons of inflammation, and the inflammation is so intense that you really can't see the residual nevus cells. So just realize in some cases you just get so much melanocytic, so much lymphocytic infiltrate that it obscures the ability to see the melanocytic lesion. Here you can see it. It's not as obvious here as it is on the other side. So over here, you can really see the nest of melanocytes here. There's no real difficulty in diagnosing it over here. The other side is where it really is more difficult to make the diagnosis. So you always have to make sure when you're dealing with melanocytic lesions with inflammation that you're not dealing with a malignant melanoma that's got inflammation. This one, I think, came from a child, and it was pretty obvious halo nevus clinically, but just realize that there's, when you get extreme inflammation in any melanocytic lesion, nevus or malignant melanoma or melanoma in situ for that matter, you have to make sure that the inflammation is not obscuring the melanocytic neoplasm in the background. So in that case, you might need to go in and do special stain, SOX10, something like that, to see where if there's melanocytic neoplasm lurking in the background there. Okay, this is a punch biopsy. And this is taken from an area where there had been a nevus before. So this was maybe even an excisional biopsy. So this is an example of a recurrent nevus, okay? And you can see that there are these melanocytes at the dermal junction. There's scar and inflammation underlying it. And notice over here, there's kind of normal dermis and maybe a little bit of hyperpigmentation, but there's really no proliferation here. The melanocytic proliferation here that's at the dermal junction, we've got some slight coalescence of melanocytes and sometimes even some upward migration of melanocytes, is confined to the area overlying the scar and the inflammation. And so this is a recurrent nevus. It may have been a dysplastic nevus. I'm not sure what the prior diagnosis was. This could have even been an intradermal nevus, because sometimes you shave an intradermal nevus, recurs, comes back, and then you get a junctional component that wasn't present in the intradermal component in that situation. And the unusual features, the junctional component and whatnot, with the slight pagetoid spread, is always confined to the area where there is the scar. So if you're looking off to the side and there's no scar there, there's no inflammation, there's nothing to the side, underneath it, and it starts looking atypical, make sure you're not dealing with a malignant melanoma that was biopsied before, and then you've got a scar and recurrent nevus looking like area, but really there's melanoma in situ off to the side. So just realize that the sort of pseudomelanoma changes really need to be confined to the area above the scar. If you see the so-called pseudomelanoma changes and there's no scar, make sure you're not dealing with a true melanoma in that area. So usually these are not very difficult to diagnose. They're usually straightforward. If you're not sure, you can always get the request the previous slide, go back and look at the previous biopsy that was taken. You can, if you don't have that, still apply the criteria. Usually, and we don't really need the pre-existing material, I would say, and 90+% of these are usually so obvious, like you see here. There's area that's small and symmetrical, that's confined above the scar, that you feel pretty comfortable making the diagnosis. But if you're not sure in one of these funny cases and you just made a small biopsy of it, always request to go back and get the previous material if possible. And that's really the way to make the diagnosis if you're not 100% sure. Now let's look at a couple of slightly unusual variants of nevi. This is a nevus that's taken by punch technique. And notice it's heavily pigmented. You've got these very heavily pigmented cells that extend way down into the lower part of the reticular dermis. And if you look at the individual cells, they're heavily pigmented. So this really looks a lot like a blue nevus in many areas. But notice the cells have this area in which some of them have this almost clear staining cytoplasm. It almost looks like the cells that you see at the dermal junction in the dermis of a dysplastic nevus. So those kind of cells, those kind of nevus cells with some clear staining cytoplasm and some melanin seen kind of deep down admixed with these very heavily pigmented cells, some of which are dermal dendrocytic in nature, or dendritic, like you see over here. This is very characteristic of a so-called deep penetrating nevus. And this is a variant of a sort of a cellular blue nevus, if you will. It was named this a few years ago because the cells extend pretty deep into the reticular dermis, but it's really just a variant of a blue nevus. And you can see that it's got these very interesting cells that have this sort of clear staining cytoplasm admixed with abundant melanin within a number of the cells surrounding it. And that's very characteristic of these deep penetrating nevi. So when you see what looks like a blue nevus that's got these specific cell types that extends far down into the lower reticular dermis, you should just be thinking of a deep penetrating nevus. Totally benign lesion, not anything to worry about, no cancer, doesn't really necessarily need to be re-excised. They often do get re-excised because there's obviously a propensity to recurrence, and people obviously want to, when they see something unusual, they say, well, let's just take the theoretical chance of this possibly be turning into a melanoma 100% out of the picture. So that's not a necessarily unreasonable reason to re-excise, but it doesn't really need to be re-excised from a biologic perspective. This is another interesting variant of the nevus. We've got these cells here that have this very large amount of cytoplasm within them that's very clear staining. And this is an example of a balloon cell nevus. So when you think of the various types of melanocytes that one can see in melanocytic neoplasia of any kind, nevus or melanoma, they're basically large cell melanocytes, small cell melanocytes, like small, tiny cells in a nevus, pagetoid melanocytes, balloon melanocytes, like we see here, oval, spindle, dendritic, and multinucleated. Those are the main types of melanocytes that comprise any melanocytic lesion. So if you just think about those 8 or 9 types of melanocytes, and then you say, well, we're looking at a melanocytic lesion. Which one of those types of melanocytes are we looking at here? Well, this is mostly balloon cell melanocytes, balloon melanocytes. And over here, there's some small round melanocytes interspersed. Here's a multinucleated melanocyte. So you can see we've got several different melanocytes in here, but this is basically just a variant of a nevus. It's got a mostly balloon cell morphology. So, there is a balloon cell type of melanoma. So once again, when you're trying to distinguish between balloon cell nevus and balloon cell melanoma, you apply the criteria for diagnosis that we do in every case. We look to see if we can apply the architectural criteria first. Is it small, round, symmetrical, well circumscribed? And indeed, it looks like it most likely is here. Very symmetrical, very well circumscribed. So it stops right here, both sides of the lesion. Then you start looking at the cytology. Are there any mitotic figures? Is there any cytologic atypia, pleomorphism of the nuclei, atypicality, hyperchromaticity, any of those kind of features? And the answer to that is no. And very symmetrical, one cell looks pretty much similar to the other. So we would feel very comfortable in a case like this, signing this out as a balloon cell nevus. We wouldn't even raise the specter of balloon cell malignant melanoma in a case like this. So just another example of all the different ways that you can get melanocytic neoplasia occurring in the skin. These are all benign lesions today, but we've obviously talked in the past about melanoma, a lot of different ways of melanoma arising in the skin too. Just as there's probably, we're looking at 19 benign nevi today, there's probably 20 or so different forms of malignant melanoma that we could look at too. So it's just an interesting field, and there's a lot of different subtypes now, both genetically as well as morphologically. I'm mainly a morphologist, but now we're learning how to apply genetic features to these lesions as well. So this last one that we're going to show here is really not a separate entity itself. It's basically, here we've got a compound nevus. It may be a dysplastic nevus. It's got some elongated epidermolycia. It's got some nested melanocytes at the periphery. It's got the intradermal component. It's got the nests extending beyond the intradermal component. But it's also got some other things that are kind of interesting. It's got some inflammation in the dermis. It's got some melanophages. And then when we look at the epidermis, it's got some crust on the surface. You can see that it's got these individual cells that are necrotic in the epidermis, individually dyskeratotic cells with eosinophilic cytoplasm and pyknotic nuclei. So these are individually necrotic keratinocytes, which we normally don't see in nevi. And this is a relatively young person. There's no sun damage here. So what happened here is this person, youngish person, decided they were going to maybe go outside and go to the beach, and they got sunburned and developed a sunburn in association with their nevus. And that can induce some unusual findings. It can induce some transepidermal elimination of some melanocytes in association with the dyskeratotic keratinocytes, like you see over here. And that can sometimes simulate malignant melanoma. It's not melanoma. This phenomenon takes about 6 weeks to go away completely. So in other words, if you were to bring this person back, let's say they came into your practice and they had a sunburn and they had a nevus, and they said, oh my goodness, this nevus is beginning to bother me. It's kind of itchy, and maybe because of the sunburn. And then you take a biopsy of it, it could look very much like this. And beware of someone looking at this and overcalling this melanoma arising in a nevus in a young person when it's just a phenomenon that occurs because of sun damage. So it's not melanoma. It's not melanoma arising associated with the nevus. It's basically just an epiphenomenon that gets induced by the sun damage. And it takes about 6 weeks to go away. So if you brought that person back, if they had a sunburn in their nevus, say, well, okay, if you're worried about the nevus, and maybe I'm a little bit worried about the nevus, let's see you back in a couple of months, and then we're going to biopsy it at that time. By that time, all these changes here would go away. and no one would raise any potential specter. So if you're, normally a good dermatopathologist look at this and just brush it off and say, nothing to worry about here. But if there was some worry, you could always just say, let's wait 6 to 8 weeks and then let's rebiopsy it, or take the first biopsy, if you will, and then make sure then this wouldn't even come up as a question. So that's an example of a lesion that has been sunburned and then biopsied. So here's another area over here. Look over here. You actually got some significant transepidermal elimination, nest of melanocytes here. Not melanoma here. I would not be one iota concerned about malignant melanoma looking just at this area right here, knowing that this lesion had been sunburned. Even if it hadn't been sunburned, it's mainly a nest, and that could even possibly be, tangentially sectioned. So again, you want to apply the full criteria when you're looking at lesions. You don't want to just apply one criterion. Just a couple of pagetoid cells above the junction, that doesn't mean something is a melanoma. You really need to have the good representative biopsy like you see here to be able to apply all these criteria. And given that this got some features that could simulate melanoma, it's really crucially important that you get a good biopsy, a good representative biopsy of something like this. If you just have a superficial shave, a small punch, 2 millimeter punch, something like that, that's not going to cut the mustard. So, we see punch biopsies of pagetoid lesions. You stain those, and they may not even stain that well with S100 protein or SOX10 or whatever. So, you really need representative biopsies to make appropriate diagnoses, especially in the field of melanocytic neoplasia. Okay, I think that's all we have for today. Showed you a lot of good examples of things in our field of melanocytic differentiation. So you need to know these. The board examination very well could ask you many of these I've showed you today. I'm not sure they're going to get into some things like a desoplastic Spitz's Nevis. That's pretty, that's kind of esoteric, but they could very well show you halo Nevis, could very well show you Mucosal Lentigo, very well could show you Becker's Nevis. So make sure you know the criteria for these lesions. Make sure you know the simulators of these lesions, like the sunburn Nevis and those kind of things. And if you put all these things together, apply these criteria, you can be able to make accurate diagnoses more often than not. All right, thanks again, and we will see you in the future. Take care.